Hello students, I am Dr. Chelja, Assistant Professor from the Department of Conservative Dentistry and Endodontics from Vinayaga Mission Shankaracharya Dental College. Today we will be discussing the topic root canal irrigants. I will be covering the topic introduction, the definition, the benefits of irrigation, the properties and the classification of various root canal irrigants, as well as the newer root canal irrigants which has been introduced in the recent years, the disinfection protocols and the challenges of irrigation, and I will be concluding with references. First, basically the effectiveness of an endodontic files, rotary instrumentation and irrigating solutions and the chelating agents will basically help you to clean, shape and disinfect the root canals, underpins the success and the longevity and the reliability of a modern endodontic treatments. So, numerous measures have been taken to reduce the number of microorganisms in the root canal, including the use of various instrumentation techniques, irrigation regimes and intracanal medicaments. So, despite the meticulous cleaning and shaping of the root canals, at least 35% of the root canal surfaces still remain uninstrumented. This was found by Peters in the year 2001. So, the use of the chemical agents during the instrumentation to completely clean all aspects of the root canal system is just centralized for a successful endodontic treatment. In this, the irrigation dynamics will play a very important role, and this effectiveness will depend upon the working mechanism of an irrigant and its ability of the irrigant in contact with the microorganisms and the tissue debris in the canal. So, according to Cohen, the irrigation dynamics was defined as how the irrigants flow, penetrate and readily exchange with the root canal system as well as forces they produce. And irrigation is basically defined as to wash out a body cavity or wound with water or a medicated fluid. And disinfectant, meanwhile, is defined as an agent that destroys or inhibits the activity of microorganisms that cause disease. So, the basic objectives of an irrigant will be three. First one is the mechanical objective, second one is the chemical objective, and the third one is a biological objective. The mechanical and the chemical objectives were as follows. First, it has to flush out the debris, then lubricate the canal, dissolve the organic and inorganic tissues and prevent the formation of a smear layer during instrumentation or dissolve it once it has formed. The biological objectives will be as it should have a high efficacy against anaerobic and facultative microorganisms, it should inactivate the endotoxin, and it should be non-toxic when they come in contact with the vital tissues, and it should also not cause an anaphylactic reaction. So, the efficacy of a root canal irrigation in terms of debris removal and eradication of the bacteria basically depends on the factors like penetration depth of the needle, the diameter of the root canal, the inner and the outer diameter of the needle, the pressure in which the irrigation is done and the viscosity of the irrigant, the velocity of the irrigant at the needle tip, the type and the orientation of the needle bevel. First is the penetration depth of the needle. The size and the length of the irrigation needle should be in relation with the root canal dimension in order to improve the effectiveness of the irrigation. Pastly, large size needles like 21 to 25 gauge were commonly employed, but these needles found very hard to penetrate beyond the coronal third of the root canal. And so recently, finer diameter needles like 28 gauge, 30 gauge or 31 gauge have been advocated because these can reach farther the canal even to the working length. Next is the diameter of the root canal. The apical diameter of the root canal also have an impact on the needle penetration depth. Basically, a 27 gauge needle barely reaches the middle third, whereas if you use a 30 gauge needle, this side venting needle you can even reach the apical end in an adequately enlarged canals. Next is the inner and the outer diameter of the needle. The external needle diameter is basically of the relevance with the depth of the introduction into the root canal and for the rigidity of the tip. So, commonly this 27 gauge needle will have an external diameter of 0.42 mm and the smaller irrigation tips will have an external diameter of around 0.32 mm. So, this Stopto Flexi tip needles which was introduced basically is a 30 gauge needle which was fabricated from nickel titanium in order to improve its penetration into the curved root canals. Next is the irrigation pressure. The speed of the plunger determines the velocity with which the irrigant is extruded. Narrow needles will basically require more pressure to extrude the irrigant, whereas higher velocity than the large size needles. So syringe can reach to a flow rates at least up to 0.20 to 0.25 ml per second even when combined with fine irrigation needles. The type and orientation of the bevel of the needle is very important for the safety of the irrigation and to prevent the extrusion of the irrigant through the apical foramen. So it is basically found that the side vented, all the double side vented found to have the least maximum shear stress concentrated on the wall facing the outlet. The benefits of using a root canal irrigants in a root canal treatment is basically the removal of the particulate debris and wetting of the canal walls, the distraction of the microorganisms, the dissolution of the organic debris, the opening of the dentinal tubules by removal of smear layer, the disinfection and cleaning of areas inaccessible to the endodontic instrument. So basically, according to Cohen, the properties of an ideal root canal irrigant should be, it should be an effective germicide, fungicide, non-irritating to the periapical tissues, it should remain stable in a solution, it should have a prolonged antimicrobial effect, it should be active in the presence of a blood, serum or a protein derivatives of the tissue, it should have low surface tension, not interfere with the repair of the periapical tissues, and it should not stain the tooth structure. And it should also be capable of inactivation in a culture medium, and it should be able to completely remove the smear layer and be able to disinfect the underlying dentin and its tubules. It should be non-antigenic, non-toxic, non-carcinogenic to the tissue cells surrounding the tooth, and it should be relatively inexpensive. So according to Kanjasamy D et al., the irrigants were classified into chemical agents, natural agents. Natural agents are basically the green tea and Trefalis. The chemical agents are further classified into tissue dissolving agents, which is sodium hypochlorite, antibacterial agents, which can be further classified into bactericidal, bacteriostatic, and then the chelating agents, which is mild chelators and a strong chelators, and combination products which had both the property of a tissue dissolution as well as an antibacterial property. According to Stock, it was classified into chemically inactive solutions and chemically active solutions. Chemically inactive solutions are basically the normal saline or the local anesthetic solutions, and the chemical active solutions are basically broadly classified into two: alkaline and acidic. Alkaline are basically the sodium dioxide, urea, sodium hydroxide, sodium hypochlorite, potassium dioxide, chloramine, and the acidic solutions are the organic acids like the citric acid, malic acid, tannic acid, and the inorganic acids. Oxidizing agents like 3% H2SO4, urea peroxide, glyoxide, and the proteolytic enzymes like streptokinase, enzymol, purified trypsin, and papain. Chelating agents are the EDTA, EDTAC, RC prep, and the other agents irrigating solutions are the chlorhexidine, gluconate, glutaraldehyde, oxidative potential water, 1% panthenidal, and calcium hydroxide solution. First, let us move on to urea. Urea is basically a white, odorless crystalline powder. It was introduced by Belchman in the year 1951, who suggested that 30% urea solution can be used as a root canal irrigant. It was found to have a mild solvent action against necrotic tissue and pulp. The mechanism of action is basically the denaturation of proteins by destroying the bonds of the secondary structure, which will result in the loss of the functional activity of proteins, and it will also chemically debride the wound by softening the underlying substrate of the fibrin. But the disadvantage is that it lacked an antibacterial action. Next is the urea peroxide, which is basically a white crystalline powder with a slight odor, and it was soluble in both water, alcohol as well as glycerin. This urea peroxide dissociated into urea plus hydrogen peroxide. This mechanism of action was basically an antibacterial action because of the release of the hydrogen peroxide, and this peroxide then breaks down and liberates large quantities of oxygen, which will cause a bubbling effect, and this will help in flushing out the debris from the canal. Next is the glyoxide, which is basically a 10% carbamine peroxide with an anhydrous glycerol. This glycerol will help you to increase the stability of the urea or the carbamine peroxide solution, and it will increase its shelf life and the lubricant action. Next, the advantage of this glyoxide was that it was very better tolerated in the periapical tissue than the sodium hypochlorite. It had a greater solvent action and it was more germicidal, and it also facilitated the negotiation of the tortuous canal because of the slippery effect of the glycerol, whereas the chelating agents, it reacted with the dentin and it causes root perforations or ledging in the softened wall. This action will not occur with the glyoxide. So according to Wien, it was found that glyoxide can be used as a main irrigant in small canals until the size 20 is reached, and then we can switch it to sodium hypochlorite. Next is the local anesthetic solutions, which come in the sterile packaging and it can be dispersed using the small gauge needles. The advantages was it was very easy to use, readily available and a safe to use, but the disadvantage, it does not have any role in managing an infected root canals as they have no bactericidal action. Next is the physiological saline. From the biological point of view, it was found to be least apical tissue irritation or damage, biocompatible and least amount of cell lysis, but this undergoes only a gross debridement and lubrication. It was only able to flush out the debris as thoroughly as the sodium hypochlorite, but it did not remove the smear layer, it just merely flushed out the superficial debris and it had a poor antibacterial properties. Therefore, this should not be used only as a root canal irrigant, it can be used as an adjunct, or it can also be used as a final flush of the root canal to remove any irrigant left inside the root canal, as so it will help to maintain the pH and also does not allow any interactions or reactions between the chemical irrigants or against the canal wall. Next is the sodium hypochlorite. This is the most commonly used root canal irrigant. It is available in various concentrations from 0.5 to 5.2%. It is a very potent antimicrobial agent and it effectively dissolves pulpal remnants and organic components of the dentin. It also provides gross debridement and lubrication of the canal. According to Engel, it was basically used as an unbuffered solution at a pH of 11 in higher concentrations, which are buffered then into a bicarbonate buffer at a pH of 9. And this was commercially available at 5% with a high alkaline pH of 11.5. This can be diluted in a ratio of 1:1 or 1:3 ratios with water to produce a 2.5 or a 1% solution respectively for an endodontic purposes. The mechanism of action is basically when a sodium hypochlorite, if it contacts the tissue proteins, it will form into nitrogen, formaldehyde and acetaldehyde, and this peptide links will be just fragmented and disintegrated, which will permit the hydrogen in the amino groups to be replaced by chlorine, forming chloramines, and this necrotic tissues and the pus will be dissolved and the antimicrobial agents can be better reach the infected areas. So basically the mechanism of action of sodium hypochlorite is three. First is the saponification reaction, second one is the neutralization reaction, and the third one is the hypochlorous acid formation. So saponification reaction is basically the sodium hypochlorite will act as an organic and a fat solvent which will degrade the fatty acids and then will transform the fatty acids and glycerol, reducing the surface tension of the remaining solution. The second one is the neutralization reaction. In this, the sodium hypochlorite will basically neutralize the amino acids by forming a water and a salt, and with the exit of these hydroxyl ions, the pH will be reduced. The third one is the hypochlorous acid formation. When the chlorine starts to dissolve in the water and in contact with the organic matter, it will form hypochlorous acid. This is basically an oxidizer, and this hypochlorous acid and the hypochlorite ions will lead to amino acid degradation and hydrolysis. So this hypochlorous acid is basically considered as a stronger oxidant than the hypochlorite ion. The solvent action, basically this is a most common irrigating solution which is used to dissolve the organic matter, and sodium hypochlorite will act both on the necrotic tissue as well as on the vital tissue. The effect is basically weaker. Several studies, they have found the tissue dissolving capacity of the sodium hypochlorite is basically dependent on the concentration. So it has been reported that if a continuous agitation of 2% sodium hypochlorite, it dissolves the soft tissue as fast as the non-agitated 6% sodium hypochlorite solution, and also heating the solution from 45 degrees Celsius to 60 degrees Celsius also speeded up the dissolution. Sodium hypochlorite is basically a strong base. So this high pH is basically responsible for the antimicrobial effectiveness. Hydroxyl ions basically released will interfere with the cytoplasmic membrane integrity due to the irreversible enzymatic inhibition and the alterations in the cellular metabolism and the phospholipid degradation, and between pH 4 and 7 chlorine will exist predominantly, and whereas above 9 the OCl will predominate. So it is that the hypochlorous acid is basically responsible for the bacterial inactivation. So the methods to increase the efficacy of the sodium hypochlorite is basically temperature, time, concentration, irrigation activation, and you can combine with other irrigants. Temperature, increasing the temperature will basically improve their immediate tissue dissolution capacity and the antimicrobial activity. An increase of 25 degrees Celsius will basically increase the sodium hypochlorite efficacy to up to 100 times. So 0.5% sodium hypochlorite, which is heated to 45 degrees Celsius, it basically dissolved the pulp tissue, which was similar to 5.25% sodium hypochlorite at 20 degrees Celsius, and when it was heated to 60 degrees Celsius, we noticed almost complete dissolution of the pulp. So the various devices which is used for heating the syringes are basically the system heat resources, and as soon as the irrigant touches the root canal system, the temperature will reach to the body temperature. And some authors also recommended in situ heating of the sodium hypochlorite. This is basically done by activating the ultrasonic or the sonic tips. Concentrations, basically the NOCl in a higher concentration is more effective against the E. faecalis and the Candida albicans, but it was found to be cytotoxic. So Rosenfeld et al. He demonstrated that 5.25% sodium hypochlorite, it dissolved vital tissue in addition to the necrotic tissue, and it was found to be significantly better than 2.61% and 0.5%. Time, there wasn't conflicting evidence regarding the time course of the antibacterial effect of the sodium hypochlorite, because the difference was due to several factors, like some had organic matter, inflammatory exudate, tissue remnants and microbial biomass. This could weaken the antibacterial effect of the sodium hypochlorite solution. Hapasalu and his colleagues, they showed that the presence of dentin marked the delays in killing of the E. faecalis by 1% sodium hypochlorite, and in the presence of organic matter, the inflammatory exudate, tissue remnants and the microbial biomass, they consume the sodium hypochlorite and weaken the effect. So continuous replenishing of the irrigating solution should be needed, allowing a sufficient contact time, which are important factors for increasing the effectiveness of the sodium hypochlorite. So according to Gomes et al., it was found that 2.5% of sodium hypochlorite irrigation for 10 minutes was found to be more effective with a less toxicity. So according to AAE guidelines of 2021, sodium hypochlorite when left in contact with the dentin for an extended period of time was found to have an unfavorable effect on the dentin. So 5.25% sodium hypochlorite reduced the flexural strength and the elastic modulus of the dentin. As a result, on one hand, more exposure time of the irrigation within the canal walls is needed to eliminate the biofilm, and this increased time could be harmful to the dentin. So therefore, a clinician must consider all these factors when they are using a different irrigants in a clinical case to enhance the favorable properties while mitigating with the adverse effects. The irrigation activation can be done in order to increase the efficacy of the sodium hypochlorite. This is basically done using an ultrasonic activation with a small file. This movement of sodium hypochlorite can also be done with a GP cone, which will basically give you a sufficient hydrodynamic effect, making the irrigant even penetrate the narrower space. This does not basically improve the reaction rate, but it will increase the surface contact with the canal walls and also help you to reduce the vapor loss effect. We can increase the efficacy of sodium hypochlorite by combination with other irrigants, like you can combine with an EDTA, which is mostly the widely used method of irrigation, because this combination will basically help you to dissolve both the organic as well as the inorganic matters. You can incorporate some silver nanoparticles, which will basically help you to increase the greater surface area, and the density of the nanoparticles will help them to interact to a greater extent, and they are found to have an enhanced antimicrobial activity, as it will easily penetrate to the cell wall, disrupting this bacterial cell function. So the most adequate irrigation protocol consists of using a 2.5% sodium hypochlorite, which will be activated using an ultrasound, followed by a final rinse with 17% EDTA or a malic acid or cetramide, which will be combined with 2% chlorhexidine. The synergism between a calcium hydroxide and a sodium hypochlorite is basically the calcium hydroxide paste will have a tissue dissolving capacity of for up to 12 days, and they also showed an increase in tissue dissolving of sodium hypochlorite after pre-treatment with calcium hydroxide for 30 minutes up to 7 days. On the other hand, some researchers have found that the calcium hydroxide was found to be ineffective for a pulpal tissue dissolving. So in a summary, it seems that Pre-treatment with calcium hydroxide medicament may increase the tissue dissolving effect of the sodium hypochlorite. The antibacterial activity of sodium hypochlorite was found it was actively killing the vegetative forms of bacteria, spore-forming bacteria, fungi. This was basically because of the hypochlorous acid which was released when in contact with the organic debris, and chloramines also was found to interfere with the cell metabolism leading to the cell death. The effect on dentin of the sodium hypochlorite is basically affected the mechanical properties by the degradation of the organic dentin components, and the depth of the penetration of sodium hypochlorite also varied between 77 to 130 micrometer, and it also depended on the concentration, time and temperature. The enhancement in the dentin bond strength observed after a sodium hypochlorite treatment was related to deep proteinizing action. This is basically sodium hypochlorite, it had the ability to dissolve and remove the exposed dentinal collagen, and it provided a fresh mineralized dentin surface to which the adhesive resin can be applied. So, according to Prati et al., it found they produced an unusual new mechanism of micromechanical retention of the resin into a mineralized dentin. This was also known as the reverse hybrid layer formation. So, the application of sodium hypochlorite after acid etching and before the adhesive resin basically helped in removing the exposed collagen which was produced by acid etching, and it also solubilized the fibrils of the underlying mineralized matrix, creating submicron porosities, and so the adhesive resins will basically penetrate into this mineralized matrix and it will create a layer of resin infiltrated mineralized matrix. So, the advantages of using a sodium hypochlorite is it helps in tissue dissolution, antibacterial action, lubrication of canals, economical, and it was easily available, whereas the disadvantage was that it had an unpleasant taste and odor. It had an inability to remove the smear layer, it was corrosive to metals, it bleached the cloth, it caused irritation to the eyes, it may sometimes cause discoloration, and when the sodium hypochlorite is used as a final rinse, it affected the bonding of the sealer to the dentin, and the toxicity was found that in 5.25% it was more toxic. Hypochlorite accident. If an sodium hypochlorite is extruded beyond the apex, severe accidents can occur. This is basically caused when there is a teeth with a wide apex, apical construction which has been destroyed using an excessive root canal preparation, extreme pressure during irrigation, the binding of the needle tip in the root canal, and not determining the working length accurately. The symptoms will be immediate severe pain, edema of the neighboring soft tissues, and this edema can also extend over the injured half side of the face, upper lip, infraorbital region, and there may be profuse bleeding from the root canal and profuse interstitial bleeding with the hemorrhage of the skin and mucosa, ecchymosis. The patient will experience a chlorine taste and irritation of the throat after the injection into the maxillary sinus. Secondary infection is possible, and reversible anesthesia or paresthesia is possible. So, the management is basically you have to remain calm, inform the patient. For controlling the pain, anesthesia and analgesics can be administered. An extra oral cool compress should be applied for the reduction of swelling. After 1 day, warm compress and frequent warm mouth rinses should be given along with the local systemic circulation. An irrigation with normal saline immediately to decrease the soft tissue irrigation should be done. Proper recall of the patient should be done. Antibiotics is only prescribed in case of high risk or evidence of any secondary infection. Further endodontic therapy should be done using sterile saline or chlorhexidine as a root canal irrigants. In case the symptoms are worsened, you have to refer to a nearby hospital. How can you prevent this hypochlorite accident? It is basically you can isolate your tooth using a rubber dam. A good proper stain line access cavity design with an adequate coronal preparation should be done. Pre-operative radiograph should be done, adequately assessed in order to assess the root canal anatomy. Use of Leolock needles, secured attachment will help you to prevent accidental separation of the syringes. Use of side venter needles. Passive irrigation of the canals. Never the irrigant should be forced into the canal with pressure, and the irrigation needle should be placed at least 2 mm short of the working length. Next is the chlorhexidine. It is basically available in concentrations from 0.12 to 2%. The molecular structure is basically it is a strongly basic molecule with a pH of 5.5 to 7, and it belongs to a polybiguanide group, and it consists of 2 symmetric 4 chlorophenyl rings and 2 bis biguanide groups connected by a central hexamethylene chain. The mechanism of action is basically this chlorhexidine is a positively charged hydrophobic and lipophilic molecule which will interact with the negatively charged phosphate groups based on the microbial cell walls, and it will alter the cell osmotic equilibrium. So it will increase the permeability of the cell wall and allowing more CH molecule to penetrate into the bacteria, since the damage to the delicate membrane followed by the leakage of the intracellular constituents will particularly like the ATP and the nucleic acid, the cytoplasm will become coagulated and the resultant reduction in leakage will thereby cause a biphasic effect on the membrane permeability. Why this chlorhexidine is basically preferred? This is basically due to the substantivity product. There is a reversible reaction of the uptake and the release of chlorhexidine which will help you to substantivate the antimicrobial effect for a longer period of time. In case if this chlorhexidine reacts with sodium hypochlorite, it will produce you an orange red precipitate which is basically a parachloroaniline, and it was found to be carcinogenic in humans. This was found to be toxic in humans with short-term exposure, which will result in cyanosis, which is basically a manifestation of a metglobin formation. And when chlorhexidine interacts with EDTA, it forms a white precipitate rather than undergoing a chemical reaction. So the advantages and disadvantages of chlorhexidine is as follows. The advantages are there was no bad or smell or taste, it was not irritating to the periapical tissue, and it did not cause any bleaching of the cloths. But the disadvantage, it lacked the tissue dissolving capacity and it had a minimum effect on the biofilms. Next is the hydrogen peroxide. It was used in a concentration of 1% to 30%. It is basically a relatively stable solution. It will degrade into water and oxygen. This was basically used for having an antimicrobial and a cleansing action. 30% hydrogen peroxide has been recommended as first step in the tooth surface disinfection after a mechanical cleaning. Next are the decalcifying agents. Basically, the smear layer is a surface layer of debris which is retained on the dentin or another surface after instrumentation with either the rotary instruments or the endodontic files. This will basically consist of the dentin particles, remnants of vital or necrotic pulp tissue, bacterial components, and the retained irrigants. Some researchers found that you have to remove the smear layer. Some researchers said that you have to retain the smear layer. Since the researchers who emphasized on the importance of removing the smear layer, they said that these contain necrotic debris, bacteria, and their byproducts. So they will act as a reservoir for the microorganisms and also prevent the sealer penetration into the tubules. So in order to remove the smear layer, decalcifying agents such as EDTA, malic acid, peracetic acid was introduced, which helped in preventing the apical blockage and aid in disinfection by improving the access of the solutions through the removal of the smear layer. First, the EDTA, it is used in the concentrations between 10 to 17% with a pH of 7 and 8, but the optimal pH for a demineralizing efficacy is between 5 to 6. It had a weak antibacterial activity. On direct exposure, this EDTA, it extracted the bacterial surface protein by combining with the metal ions, and it eventually led to the bacterial death. Next is the Aciprep, which is the commercially available one decalcifying agent, which is basically a combination of 10% urea peroxide and 15% EDTA along with glycol. In this, the urea peroxide will have an antimicrobial effect, and the glycol is the lubricant which will prevent the oxidation of EDTA by urea peroxide. Next is the HEBP, etrodonic acid. It's basically a weak chelator and it has a neutral pH. This has a constant calcium binding capacity, so its chelation effects basically depends on its concentration. 18% etrodonic acid and 17% EDTA showed similar efficacy in smear layer removal. Next is the MTAD and the tetracline. MTAD is basically the mixture of tetracycline acid and detergent. It was introduced by Thorabinajed and Johnson. This had a 3% doxycycline, which helped in had an bacteriostatic, and it was a broad spectrum antibiotic, and it also helped in promoting the healing. It had 4.25% citric acid, which was bactericidal, and it helped in removing the smear layer. Next is the 0.5% polysorbate or the tween 18, which is the detergent. This helped in decreasing the surface tension and increasing the penetrability. Next is the Q mix, which was introduced in 2011. This contains CHX analog, triclosan, and EDTA as a decalcifying agent. 5 ml of Q-mix was recommended to be used as a final rinse at the end of instrumentation after sodium hypochlorite irrigation. The newer root canal irrigants introduced was this. First one is the superoxidized water. It is basically the electrochemically activated water or the oxidative potential water. It is basically a saline which has been electrolyzed, and it was commercially available as Cherlox. The second one is the ozonated water. It is basically a chemical compound consisting of 3 oxygen atoms. It is a highly energetic form than the normal atmospheric oxygen. It is a powerful antibacterial agent, and ozone at a low concentration like 0.1 ppm is sufficient enough to inactivate the bacterial cells including spores. The mechanism of action is it will help in destruction of the cytoplasmic membrane and the destruction of the cell walls of the bacteria, and in turn it will increase the membrane permeability, and the ozone molecule will enter into the cell wall and it will cause the death of the microorganisms. Next are the herbal products. This is basically a plant derived material or the preparation which will either contain the raw or the processed ingredients. It has an antibacterial property, anti-inflammatory, antioxidant, and it is also biocompatible. This natural plant extracts will basically take the advantage of antibacterial activity of the polyphenolic molecules. The major advantage is it is an easily available, cost effective, longer shelf life, low toxicity and lack of microbial resistance. First is the Triphala. It was found to kill 100% of the E. faecalis within 6 minutes. So this is basically a fruits that are rich in citric acid and aid in the removal of the smear layer. Next is the green tea polyphenols. This is prepared from the young shoots of the tea plant called Camellia sinensis. This shows statistically significant antimicrobial effect against the E. faecalis. It takes 6 minutes to achieve 100% killing of E. faecalis. Next is the apple cider vinegar. This also was found to have an antiseptic agent due to its medicinal properties, and this should be used as an auxiliary solution in the chemomechanical properties when compared with the sodium hypochlorite and EDT. Propolis, this is basically a resinous beehive product, and Durati et al. He found that the influence of the reduction of acid production by S mutants in the dental biofilm besides the inhibitory activity of the F-ATPase activity of S mutants. Next are the antibacterial nanoparticles. Nanoparticles is basically the dimensions which have range of around 1 to 100 nanometer, and this was found to have a broad spectrum activity of antimicrobial. And the successful application of nanoparticles in endodontics basically depend on both the effectiveness of the antibacterial nanoparticles and also the delivery methods to disperse these particles into the anatomical complexities of the root canal systems. First is the chitosan nanoparticles. This was basically developed for its antibacterial and drug delivery application. This has an excellent antibacterial, antiviral and antifungal properties. Along with chlorhexidine, when this chitosan particles was found, it was potentially eliminated all the E. faecalis, and it also promoted towards the tissue regeneration using a membrane barrier in the periapical surgery. Next is the silver nanoparticles. This produced an antibacterial effect by acting on multiple targets, starting from the interaction with the sulfhydryl groups of proteins and DNA, then altered the hydrogen bonding or the respiratory chain. They unwinded the DNA and interfered with the cell wall synthesis or cell division. So the recommended disinfection protocol suggested for a root canal treatment. First, you have to use a 2.5 to 5% sodium hypochlorite throughout the instrumentation procedure until the final shape of the canal is achieved. Activate or heat the fresh sodium hypochlorite for approximately 30 seconds with fresh solution per canal. Apical negative pressure devices can also be used to enhance the apical irrigation without any extrusion. The smear layer removal can be done using EDTA, citric acid, for around approximately 1 minute, which can be activated, or an apical negative pressure is optional. The final rinse options will be either fresh hypochlorite for approximately 1 minute, chlorhexidine, Q-mix, or you can dry it with the paper points and obturate it. In case of a non-vital teeth, irrigation will be basically initiated using a sodium hypochlorite for its bacterial effect, or chlorhexidine 0.2% for 10 minutes for the elimination of various bacterial types present in the root canals. Then a distilled water can be used to neutralize the effect of these irrigants. EDTA in a liquid form can be used to eliminate the smear layer and opening of the dentinal tubules. At the end of the preparation, a distilled water or saline can be used in order to eliminate the chemical agents or neutralize the effects. In case of resorption, when you suspect an internal resorption, the irrigation sequence will same as of a vital tooth. but the sequence will be followed by the use of a citric acid, which was 50%, for a 10 minutes in order to remove the granulation tissue or obtain a smooth dentinal walls. And this citric acid can be eliminated by using a sodium hypochlorite or a distilled water. In case of weeping canal, the irrigation will be done with a normal saline, then the canal will be irrigated with the chlorhexidine, and calcium hydroxide will be placed as an intracanal medicament. In case of abscess, irrigation can be done using 2.5% sodium hypochlorite with an open 30 gauge needle at 2 mm less from the working length. Then the canal will be irrigated with normal saline. In case of one pulp polyp, the irrigation will be done with a 5 ml of 5% sodium hypochlorite solution, and irrigation will be done using a normal saline. In case of a hyperinflamed pulp, the irrigation will be done using normal saline, then it will be irrigated using sodium hypochlorite along with EDTA. In case of open apex, you have to be very careful that the extrusion of irrigants does not happen, otherwise it will injure your periapical space. So lower concentration of sodium hypochlorite will be advised, like 1.5% sodium hypochlorite, 20 ml per canal for 5 minutes, and then it will be irrigated with saline or EDTA, 20 ml per canal for 5 minutes with an irrigating needle positioned above 1 mm from the root end to minimize the cytotoxicity to the stem cells in the apical tissues. So in order to summarize, in case of a necrotic pulp, sodium hypochlorite along with chlorhexidine should be used. In case of vital pulp exposure, sodium hypochlorite along with hydrogen peroxide can be done. In case of a calcified or a sclerotic canal, EDTA along with the sodium hypochlorite can be used. Always the final rinse to remove the smear layer will be EDTA or sodium hypochlorite. In case of retreatment, chlorhexidine or sodium hypochlorite should be used. The challenges of irrigation. In case if you are using only EDTA or the other irrigants, this inorganic matter, it did not remove the inorganic matter. So therefore the use of hypochlorite during instrumentations cannot be omitted, and the smear layer is created only on the areas touched by the instruments. So the delivery of these irrigants will generally be unproblematic. However, careless irrigation with needles introduced only to the coronal and middle parts of the canal is likely to have incomplete removal of the smear layer in the apical root canal. Next is the dentin erosion. One of the basic goal of an endodontic treatment is to protect the tooth structure so that the physical procedures or the chemical treatments will not weaken the dentin. But this decalcifying agents like EDTA and MDTA was found to show an increased dentin erosion than the Q-mix. Next, mechanical properties like the micro hardness. Most of the irrigating solutions like the sodium hypochlorite, EDTA and its combinations, they exhibit reduction in the micro hardness, which increased with the increase in the concentration, and the sodium hypochlorite also altered the resistance to fracture when used in increased concentration for a longer period of time. 17% EDTA for 3 minutes did not affect the elastic modulus, but if you increase the contact time, it reduced the elasticity. And EDTA was also found to cause some roughness on the dentin surface. So the lowest sodium hypochlorite concentration which was capable of altering the mechanical properties were 1% for micro hardness, 0.5% for flexural strength and 0.6% for elastic modulus. In case there are an instrument part of the root canal system, how will you clean it? This is basically relying completely on the chemical means, and so use of sodium hypochlorite is a key factor in obtaining the desired results in this area. Biofilm, this can be removed or eliminated through the following methods. You can either use a mechanical removal by the instruments, dissolution by the hypochlorite, or the detachment by the ultrasonic agents. Other chemical means is like you can use chlorhexidine, which will kill the biofilm bacteria if it is allowed for a long period of contact time, but it lacked the tissue dissolving ability. So the safety versus the effectiveness in the apical root canal is irrigation must basically maintain two important goals. One is the safety, and the second one is the effectiveness. This point is particularly true for an most important irrigant, that is the sodium hypochlorite, because in case the other irrigants can also cause pain or problems if they gain access to the periapical tissues. So the eradication of the microorganisms in the apical canal should be of a key importance to the success of the endodontic treatment. And sufficient exchange of hypochlorite with the other irrigants in this area will basically keep the apical pressure of the solutions minimal, and it will also help you to achieve the goal of irrigation of the apical root canal. So a better understanding of the fluid dynamics and the development of new needle designs will for the irrigant development is basically the two important areas which will help deal with the challenges of the irrigation in the most apical part of the canal. So I like to conclude that irrigation basically has a key role in the successful endodontic treatment, and although hypochlorite is the most important irrigating solution, no single irrigant can accomplish of all the tasks required by an irrigation. So factors such as concentration, exposure time, all should be considered in order to mitigate the deleterious effect without interfering with the antibacterial properties. In addition, it is basically very necessary to know the characteristics of each solution in order to decide which will be more suitable to ensure the success of the endodontic treatment and causing minimal mechanical damage. Therefore, newer developments in the root canal irrigants as well as more clinical studies in this aspect is required for the safer and effective irrigation. Thank you all for hearing this lecture. Thank you.